Sir, the guidelines currently, as we discussed, were the cross-sectional imaging of CT with MRI with bone scintigraphy, sir. But why in discussion related to PSMA PET is the lymph node metastasis, the accuracy, diagnostic accuracy of the CT or the MRI in detecting the lymph nodes, you can see that the sensitivity and the specificity is low. Importantly, the sensitivity is low in detecting the lymph node metastasis. So the reason behind would be the picking up the lymph node metastasis by the cross-sectional imaging would be better if the size of the lymph node is more than 8 millimeters based upon the morphological character and the imaging quality, imaging appearance of the lymph node. But if you see here, it is 80% of the metastatic lymph nodes are of size less than 8 millimeters. So this could be the reason for less pickup rate of the cross-sectional imaging in lymph node metastasis, especially speaking pertaining to the prostatic malignancy. So in this background, why PSMA PET has gone important now is it's a higher diagnostic accuracy. It seems important in the staging as well as the management, both. So few brief points about why PSMA has been chosen, because the normal prostate also expresses the prostate-specific membrane antigen. The exact function of it was not being described. It is localized to the cytoplasm and the apical part of the epithelium in the prostatic ducts, in the normal prostatic benign conditions. Whereas in neoplasia or dysplasia transformation, there is a transfer of the PSMA from the apical towards the luminal side of the ducts. That itself explains the more expression and the affinity towards the prostate-specific membrane antigen scans, which will give better information. So this is the structure of the prostate-specific membrane antigen. It is a transmembrane glycoprotein 2 cluster. It has a large extracellular domain and then a transmembrane region and an intracellular domain. The importance was initially the positron emission tomography scans were done based upon the ligands being attached to the intracellular domain, sir. Where I can give an example later on, 7E11 was described, which gets attached to the intracellular domain. But these are large molecules, and in case of a viable tissue, they have a low positive predictive value because the taking up of the cell, the ligand inside the cell to attach to the intracellular domain is less. So now they have recently studies were done to develop a low molecular weight ligands. So of them, one of is the PSMA 11 and 617. These are the ligands which will attach to the extracellular domain. So now the PSMA PET scans which we do are those ligands which attach to the extracellular domain. Later it will cause internalization of the tracer, which will show the uptake in the cell. So the advantage of PSMA PET is it is expressed more in case of high-grade prostatic carcinomas and metastatic CA along with that of the castration-resistant prostate carcinoma. This being the increased expression and in the high-grade lesions. That is what we will take an advantage in case of a primary primary modality of investigation. And you can see that it is weakly expressed in the normal prostate. So
just to add, the ratio is 1:1 in normal prostate and PSMA. The ratio is just 1.
Yes, sir.
1:1. Yes.
But 30-fold increase in case, 10 to 30-fold increase in case of malignancies. The more than 10-fold increase of the PSMA expression is there in case of malignancies, high grades. And an exception is the neuroendocrine malignancies and those solid tumors which are vascular will have an low expression of these PSMA. The neuroendocrine carcinomas will not have these expression, but it is also seen in case of other solid tumors, which I will show in brief. So these are the glands which can have a normal uptake of the prostate specific membrane antigen also. So studies are being done to project it onto the renal malignancy also in the current settings. See, in the salivary gland uptake, spleen and the intestine, colon, all can have the uptake of the prostate-specific membrane antigen study. So, before the prostate-specific membrane antigen, what were the positron emission tomographies which we are using? From the beginning, we got the 11C choline PET scans, we got it. Later on, followed by the fluorodeoxyglucose and the technetium-99 scans. They also picked up the metastatic lesions as well as the malignancy in the primary side. The thing is, the sensitivity is less, especially in level of low PSA, because they studied these in case of biochemical recurrence. I mean to say recurrent prostate malignancy. So there, in view of low PSA expression, the sensitivity of these tests has come down. Hence, we came towards the new radio tracer materials, which I will show you here. So this is the component which we have an nuclear pharmaceutical, which we get it. As I described, we have a ligand, a chelator should be there, and an isotope. So the ligand, as I described, sir, the recent one which we are using is commonly used and available and more affinity to the extracellular domain. That is the urea-based ligand, sir. That is glutamate, urease, and lysine-based ligand. And the chelator will be attached to the ligand in situ. That is a common one is the HPEDCC, which has been expanded down there. And the isotope which we are using currently for the PET scan of PSMA are fluoride and the gallium. So that depends based upon the emitter which we use, whether we are using a cyclotron, or we are using a generator for the production of the radionuclide. Depends upon what we are using that. So gallium 68 and the fluoride 18 are the commonly used for the primary staging as well as the recurrent of the biochemical recurrence in case of malignancy. Technetium-99 is being used mainly to guide the radiological improvement, like following radiotherapy, the response, how it is, and intraoperative, if you are planning any surgeries, means if you can do the technetium-99 scintigraphy and picked up by the gamma camera, if you want to see the lymph node uptake intraoperatively and do a proper dissection. So that it can be useful. Whereas the lutetium-117 and these yttrium these are beta emitters which are mainly useful in case of theranostics like radiotherapy which we are using. So lutetium-117 and the yttrium indium are being used for that purpose. So these are the radio tracers which we are now commonly being available and being used. Common one I will describe, that is the gallium 68, which is being generated from the germanium generator. The advantage why is being used more nowadays is because of the less cost and the life of 270 days, and we can use it for 2 to 4 patients in a day. But it is can be used in a small, means like centers where the numbers are high, because we can use it in a day of 3 to 4 patients, and the cost around 20 lakhs per year. Whereas which I described for the fluoride usually is from an cyclotron, sir. So which needs an larger equipment, and as well as you need to have more cost inbuilt also in that. So that is the advantage of the generators. So these will be distributed to the centers where they are doing the scan, so that they can pile up the patients on the same day and finish. So that is the advantage of having the generators. Briefly about the technique and how we do that. So adequate hydration, the furosemide is being given because this prostate-specific membrane antigen is being excreted through the kidneys into the urine system. So the urinary tract, kidneys and the bladder also will show the ability. So since if you want to know the status of the lymph nodes, especially like in this case we discussed, so the Lasix will have give the advantage of draining the urine, so that you can have a better information about the lymph nodes, especially in the lower ureter level, the ILAX, what we discussed. And the administration is 1.8 to 2.2 megabecquerels per kg is the standard dose, and is given as an intravenous administration. The acquisition is taken as 60 minutes. That is the advantage. We have a longer intervals to take the images after giving an radio tracer. So image acquisition, there is also a protocol for that. First, as we discussed, it is a PET CT. So they will superimpose the CT or superimpose the PET images on the CT scan. So first they will perform a CT scan from the skull base to the mid thigh, and the PET is acquisited in a reverse direction, sir, from caudal end to the cranial end. So this will take an acquisition duration of 2 to 4 minutes. Then the images are superimposed and we'll get the information. Reporting, as we discussed the technical details and dosage, and important thing we need to mention in the report was the location where it is present, the extent and the intensity of the PSMA avid lesion. That is what important in the reporting. So the degree of the avidity is expressed as standard uptake value. Either the mean or max, what they will calculate, it is based upon a standard mathematically calculated formula, sir. So according to the studies, what they mentioned is a standard uptake value of 3.9 can be considered with more than 95% sensitivity of saying it is a malignancy, sir. So if the SUV comes to up to more than 3.5, that is, say, for example, 3.5 more than that, you can consider that it is a metastatic lesion. That means there is a malignancy seen in that. So this is the basic about the ligands and the radiotracer and the technique and acquisition reporting. So coming to the indications currently where we can use the PSMA PET scan. We discussed it as localization of the biochemical recurrence, but now the trend is being shifted towards the primary staging also, especially in case of a high-risk prostate carcinoma.
Can you just go back on that slide?
Yes, sir.
I want you to remember when you say primary staging of high-risk carcinoma prostate,
sir,
please look at that reference. That is very important. Hoffman's reference, the Australian study.
Yes, Australian study, yes, sir.
But read it very carefully. Before curative intent surgery or radiotherapy.
Yes, sir.
Primary staging of high-risk carcinoma prostate before curative intent surgery. What did you say here? The guy, your patient had a PSA of 200. He was not curative intent. That's what I was telling you. When you have curative intent, then these things come into place.
Yes.
Because you want to be sure that you have a high-risk cancer or whatever it is, it picks up nodes, it picks up this, and whether you want to change from surgery to radiotherapy or something else. This is a very specific study addressing a very specific question. It was not just blanket use for everybody.
Yes.
Yeah.
Understood.
Yeah.
So regarding the same question what sir asked, whether the PSMA PET would be better than conventional imaging for staging of high-risk prostate cancer. So this would be an example where we can see he's an 70-year-old male patient with biopsy-proven high-risk prostate carcinoma with a Gleason score of 9 and PSA of 94. You can see the image of A, B, C, where you can see the prostate picking up the lesion in an axial CT and a PET imposed onto a CT. Where here in a DEF image, you can see that the axial CT cannot make out any lymph nodes very obvious. And if you see the PET image here, and I superimpose there is very obvious uptake seen in the lymph nodes, which will change the stage of the disease. And your plan of management also would rather change. So in this point of context, I would rather say that, yes, it would be beneficial to doing a PSMA PET scan as a part of primary staging also. Yes, sir, told if you are planning a curative intent.
Karnakar, can you go back to the image, please?
Sir.
D, this is just a warning for residents. If you see here, there are several soft tissue lesions or shadows which are not normal.
Yes, sir.
Yeah, they're all merged in each other. Yes. So here the use of the PET scan is in knowing what is the significance of these.
Yes, sir.
Right? So
yes.
The lesions have to be recognized at CT. I mean, I would be unforgiving of myself if I didn't pick these up on CT or MRI.
Yes, sir.
This is not the normal pelvis.
Maybe to increase the diagnostic accuracy, I can say. Sorry.
Correct. And to know what they are.
Yes, sir. So what does the impact of PSMA PET on the stage? So this, I'm quoting the study of a retrospective single center study. It is 64 patients where 8 patients are of intermediate risk category and 54 of high risk category. So if you see here, the nodal status as well as the metastatic status was upstaged following an PSMA PET compared to a conventional cross-section imaging in 23% of the patients, and also downstaged in case of 9%. Whereas metastatic status also there is an upstage and significant amount of downstage in case of an prostatic specific PSMA PET scan compared to an cross-section imaging of CT or MRI with a bone scintigraphy. So the level of confidence what they mentioned is when compared to equivocal, especially they're telling there is an equivocal diagnosis. If it is an sure shot diagnosed case of metastasis, it's okay. But if they have an equivocal diagnosis, to say it is a positive or negative, then the level of confidence has been increased with the PSMA PET scan by 20%, especially in case of metastatic disease. Second question is whether PSMA PET will have an impact on management. First, we discuss the staging. So, around the management. So, this is also they have addressed in the same study, sir. So, they mentioned that there is a change of plan which they have been taught. They have three plans, whether they have undecided in treatment, or they have a curative intent, or they have a palliative intent. These three groups they have taken among the 64 individuals. And they are given a percentage of which patients which they have thought initially based upon a CT or MRI with bone scintigraphy. But when you go with the PSMA PET scan, there is a change of 9% of patients to curative when they are thought to be an undecided previous plan. And there is a change to palliative to 3%. And undecided patients also, curative intent was increased up to 14%. So if you see the percentage in their study, there is 36% increase in the treatment category change. So this shows a little significant significance as the treatment management has been changed following an second imaging study compared to a cross-sectional study of CT or MRI. So this is what Ganesh told about the pro-PSMA study, Australian-based study, which was being published recently in Lancet, sir. So these data we have been taken from that study. So here you can clearly see that the lymph node and distal metastasis compared to a conventional imaging, what they speak is an CT. The compared to that gallium PSMA PET scan, the sensitivity and specificity are significant. I mean, to say sensitivity is at least high, and the accuracy also gone up to 92% in both the lymph node as well as the distal metastasis. If they have done an PSMA PET scan. So it is a prospective multicentric randomized study, sir. They have taken 300 individuals and they have randomized them into two groups of 150 each. And stage they have taken is more than T3, sir. And an ISUP grade of 4 they have taken. And first group they have randomized as done a CT cross and bone scintigraphy. And the second one randomization was, this is randomization. Second group were the PSMA PET. And then they have sequenced them with CT group with PSMA and PSMA group with the CT. So they have drawn the results after that. So they mentioned that the sensitivity and specificity are high when you have taken a PSMA PET scan. So here you can see, sir, here also in limiting the equivocal results when we have a decision whether we have to have a curative intent or a palliative intent. So if you see the equivocal findings on first line diagnostic image, if you take the CT where the blue arrow, mark being showed, there is equivocal percentage up to 23%. But if you take the PSMA PET scan as a first line imaging there, the metastatic disease, the equivocal chances are reducing significantly. Sir?
Hello?
Sir, can you hear me?
Yeah.
Yes, sir.
No, carry on. He's speaking to someone else.
Yes, sir. So that equivocal nature in a metastatic disease has reduced to 7%. And it is also very significant in case of pelvic lymph node metastasis, where 6% are equivocal in case of conventional imaging of CT and less than, almost close to 1% in case of an PSMA PET. So this obviously will change the management of the patient. And even distal metastasis also, there is 21 and 7 difference in equivocal patients. Same thing in case of management also. If they use first line diagnostic imaging as an CT and the first line imaging as cross-section of PSMA PET scan, the management percentage also has significant increase, like more than 10% change in the management here. And the significance is second line. Say for example, a patient has been done a cross-section imaging of CT and you have subjected him to a second line test of PSMA PET after doing a CT. There is significant difference of 5 to 25, 25%, 20% significant change is there.
Imran, can you mute your mic, please? Imran Khan, please mute your mic. Yeah, go on. Yes,
sir. So if the second line imaging after CT doing a PSMA PET scan, there is significant change in the management percentage, sir, where 5 to 25% difference you can make out there. Okay. Screen. Yeah. And the results were drawn based upon the local recurrence. So if you see here, sir, the local recurrence staging rather they mention that NPMRA has a high positive predictive value and accuracy. We see up to 92% seen. If you think an recurrence in the local region, like for example a surgery or radiotherapy post-surgery, if you see that. And if a PSMA PET scan is done, the sensitivities and the specificity is less, and the accuracy also is less in staging a local recurrence in the malignancy post-surgery or radiotherapy. But if you see the lymph node recurrence, the PSMA PET has picked up more amount of lesions, and the negative predictive value was close to 100, with accuracy going up to 90% in case of lymph node recurrence. Why? Because this has happened in view of low PSA levels also. The lymph node metastasis or lymph node recurrence pickup is high in case of an PSMA PET scan when compared to an MPMRA. MPMRA also has picked up the lymph node disease, but the accuracy is more with the PSMA PET. And extending the diagnosis to the skeletal recurrence also, see the bone scintigraphy, even though accuracy is more, but the sensitivity and specificity are even high with the PSMA PET scan also. So this shows that the metastatic diagnosis in case of lymph node and the skeletal post thing, that is a biochemical recurrence, PSMA PET would be the best option of choice to check for the extent of the disease and this management plan. So here they have given a reference values also, sir. In a PSA of less than 0.5 also you can see there is 50% pickup of the patients with PSMA PET scan. And the sensitivity has gone up to 85 to 86% when the PSA is more than or equal to 2. So this is what even this states in Campbell also. If the PSA is more than or equal to 2, obviously the sensitivity has been and diagnostic accuracy also increases up to 85 to 86% in picking up an metastasis. So is there any change in the impact of management? Yes, there is a change in management plan in more than 50% of the malignant patients with biochemical recurrence, what they mentioned. So 53% there is a change in management plan. So this is about the primary staging and well as the management. So what are the emerging indications of the PSMA PET scan? The other one is a targeted biopsy after a previous negative biopsy. So following a TRUS or following an MRI, you can fuse with that of the PET scan to have a better diagnostic accuracy of getting a positive biopsy. If you are doing an re-biopsy in a prior negative patient. Also, if you are planning a PSMA directed radiotherapy, staging before and duration during the treatment also, this PSMA PET would help us for better evaluation. And the recent advances, what we thought is a theranostics where PSMA is being directed towards the treatment. This is also been under upsurge now. And also monitoring a case of a systemic treatment. Patient is on androgen deprivation therapy and you want to monitor the patient if the PSA is doubling time is high or progressing. Especially want to take about the CRPC patient. You can check for the PSMA PET scan to look for the metastasis and monitor his management. So example is the PSMA directed radiotherapy, prior imaging with the gallium-68 PSMA PET. Initial point of slides I mentioned, the small molecules are being under now study. Among them, the PSMA 617 and INT means they are mentioned as imaging and treatment. Sir. These are all ligands classification. So they usually classified them into fluoride based as well as the gallium and other based. Fluorides are separate and they need to have an separate chelator for that and separate chelator for these PSMA, gallium, other ligands. And lutetium-117 is being used as an emerging application in PSMA-directed radiotherapy. So here you can see in an CT image where there are significantly enlarged lymph nodes. Here, this is a patient with 77-year-old with metastatic castration-resistant prostate carcinoma who has been treated with prior ADT also. There is huge lymph nodes seen in the thyroidic region. And the images of DEF were post-treatment with that of the lutetium scan. So there you can see there is obviously may not be completely resolving, but they also state that it is a fall in PSA of at least 50%. They will look at the end of 1 year. So that is what they quote in their studies also. Using the lutetium-117 theranostics, fall in PSA of more than 50% 1 year is usually they consider that as significant. So you can see there is an improvement in the lesion.
Karunakar,
Sir.
that first image,
Sir.
don't call it a huge lymph node. It's a lymph node mass.
Mass.
Okay. Again, some finicky examiner will say you think it is one lymph node.
Yes.
It's a lymph node mass. Obviously, they are matted together, which the PSMA PET scan, if you see, has actually picked up at least 3 discrete masses.
Yes, sir. Correct.
Yeah.
And also in case of monitoring of systemic treatment in metastatic prostate carcinoma, what I mentioned there, previous indication also, the RECIST criteria, what we follow, the response evaluation of in solid tumors, response evaluation criteria. This is limited because many of them would not have a measurable lymph node or a bone metastasis seen there. So that would be the limitation in these imagings. And the disadvantage of bone scan also being the flare phenomenon, which may not be helpful in the monitoring whether the treatment has been fruitful or not. So for this also, I'll give an example here.
Yeah,
so,
but
sir,
when the flare phenomenon takes place. So
yes,
the bone scan can be done at a time when the phenomenon is subsided.
Okay.
So this is a bit of a commercial pitch.
Okay, sir. No, but here they have mentioned that if you compare the PSMA PET prior treatment and after treatment, you can almost make out that there is a complete response there in the bone. Whereas if you see a bone scan spec there, maybe this still shows there is a lesion still being stable. Rather, even though it has been completely resolved. And in a plain CT, if you see, that is a sclerotic lesion post-treatment, which has been shown as still some sclerotic lesion being sitting there. So this they mentioned that as PSMA PET would be a better imaging modality in a patient with a systemic treatment to monitor his response to our management or monitor his treatment modality. So what they quoted was no absolute contraindication to do a PSMA PET scan. And in terms of radiation exposure, when compared to a conventional CT imaging and the PSMA PET CT imaging, you can see not much significant exposure of the radiation is also seen, sir. So I would like to give a key point.
A word of caution about radiation exposure.
Sir.
We might be looking at a single study radiation exposure.
Okay.
But we have to take into account, especially in patients who are on follow-up, that they might have undergone a variety of other radiation studies and radiotherapy. So all these have to be added before we decide whether we want to do anything which involves radiation.
Yes, sir. So the key would be the specific target. Since it is a prostate-specific membrane antigen, it would be the rather specific target, and the most promising results would be there in staging as well as management also. And second one, which we discussed, was in biopsy-negative patients, it definitely would be an advantageous if you are planning a targeted guided biopsy. Sensitivity and specificity are also increased compared to the standard imaging modality. And also in case of low PSA with a biochemical recurrence, the sensitivity of PSMA PET is more compared to a cross-sectional imaging of CT or MRI. And also pitfalls, small recurrences in the urinary bladder cannot be made out, and potential liver metastasis because high background activity. So you cannot make out that in PSMA PET cannot be very much advantageous in that. And neovascular of the non-prostatic cancers. And the celiac ganglion, stellate and other ganglions also means misdiagnosed would be of a lymph node sometimes because of the uptake seen in them also. And in the page disease of bone and ribs, as we discussed before, the sclerotic and the activity seen in that region may not be helpful to have a proper diagnosis of with the help of PSMA PET scan. So these, I would say, some of the pitfalls in doing an PSMA PET scan. And it is being extended into the other malignancies also. I don't want to discuss about them today, but even RCC and ablative radiotherapy being, they are using this PSMA also in ablative radiotherapy management also.
Just to add to what Mohan said about the radiation exposure,
sir,
most patients would have had a CT scan before treatment intent. And then they develop biochemical recurrence, and you go ahead and do. So you've got one CT scan, then you've got another CT scan trying to find out biochemical recurrence, and you may do a CT at that point. And then finally you do a PSMA PET. So, it's adding on. There's a lot of CT scan, and that radiation is adding up significantly to patients. It is just that these guys are old, so they may not live long enough to see the effects of radiation. But if you see children, then you are in trouble. That's what's happening to all the childhood tumors, isn't it? So we need to be extremely cautious about the amount of radiation that is being delivered to these patients by investigative modalities.
Yes.
Okay, folks, good show. This was
Well,
nice.
thank you.
But I hope you'll take this back and keep it in your minds.
Yes, sir.
Okay. Thank you all. We'll meet
Thanks.
next week.
Yes, sir.
Have a nice time till then and stay safe.